Welcome back to the deep dive. I have to be honest with you, right off the bat, when I saw the topic for today, my mind immediately went to the grocery store.
Uh-huh.
I'm thinking sports drinks. I'm thinking those neon blue bottles that promise to replenish your electrolytes after a workout.
It is the standard association. I mean,
Nice.
marketing's done a very, very good job of making us think electrolytes are something you buy in a plastic bottle when you're thirsty.
Exactly. And I thought, okay, we're going to be talking about hydration hacks for an hour. But then I opened the source material, this really comprehensive guide on electrolyte homeostasis, and I realized I was completely wrong.
Yeah.
We are not talking about Gatorade. We are talking about, like, the fundamental operating system of the human body.
That is a much, much better way to frame it. We're not just discussing thirst. We're discussing the electrical grid that keeps you alive.
The electrical grid.
We tend to think of ourselves as, biological machines, flesh, bone, muscle. But at a really fundamental level, you are a battery. You're a chemical processing plant where the difference between life and death is measured in these tiny, tiny units called milliequivalents.
And that's what kind of scared me a little bit reading this. The margins for error are just so slim.
Oh, they're razor thin.
You read these numbers and you realize that if your sodium or your potassium shifts just a few points in the wrong direction, the whole system it crashes.
Yeah, it's a high wire act. And it's one we perform every single second of every single day without even thinking about it.
Right.
I mean, we're talking about the precise life or death feedback mechanisms to keep your heart beating in a perfect rhythm, to keep your neurons firing thoughts and your muscles contracting to, move you across a room. If this grid goes down, the lights go out. Permanently.
So our mission today is to basically open up the control panel. We're going to look at the 6 critical players that run this grid. Sodium, water, calcium, phosphorus, potassium, and magnesium.
The big ones.
We need to figure out what they actually do, what happens when they go haywire, and how modern medicine steps in to fix the grid when it breaks.
And just to set the stakes a little higher, disorders in these systems affect almost every organ system you have. We're talking hormones, kidneys, the brain. They're all constantly communicating, adjusting, filtering, all to keep this delicate balance, this homeostasis.
So let's start with the big one, the absolute foundation, the ocean within, sodium and water.
It's a really apt metaphor. I mean, life began in the ocean, and in a way, we brought that ocean with us when we crawled onto land. Our cells are, for all intents and purposes, swimming in a saltwater bath.
The stats here are just wild. The text says 60% of our total body weight is water. That part I think most people have heard. But the distribution of that water is what really surprised me. It's not just one big pool.
No, not at all. It's not just sloshing around randomly. The best way to think about it is, imagine your body is a house. You have water in the pipes, that's your blood vessels, your plasma. But you also have water inside the actual rooms. Those are your cells. And then you have a little bit of water in the hallways and the spaces between the rooms.
So where is most of the water hiding? Is it in the pipes?
Nope. It's inside the rooms, inside the cells. That's the intracellular fluid, or ICF. About 2/3, a full 66% of your total body water is locked away inside your trillions of cells.
Wow, 2/3. So the rest is just in the hallways and the pipes.
Exactly. That's the extracellular fluid, or ECF. Now, here is the absolutely critical part, and this is where people get confused. The walls of these rooms, the cell membranes, they aren't solid concrete.
Okay.
They're permeable to water. Water can flow in and out freely.
So what decides which way the water flows? Is it just random? Does it just move back and forth?
No, it's very strictly controlled by a concept called tonicity.
Okay, let's unpack tonicity. I have not heard that word since high school chemistry, and I'm pretty sure I failed that test.
It's simpler than it sounds, I promise. Think of tonicity as the pulling power of a fluid.
Pulling.
And the thing that generates that pulling power is dissolved stuff. And in our bodies, that's mostly sodium. Water is attracted to sodium. It wants to go where the salt is.
It's like a magnet for water.
Precisely. So let's play out a scenario. Imagine the fluid outside your cells, the water in the hallways, suddenly becomes very, very salty. We call that a hypertonic solution.
Okay, so high pulling power.
Right. So because there's so much salt outside in the hallway, the water that's inside the cell, inside the room, it rushes out to try and dilute it.
And what happens to the poor cell when all its water leaves?
It shrinks. It loses its volume. It shrivels up like a raisin.
That does not sound good for the cell.
It is not. But the opposite is often far more dangerous. Imagine the fluid outside the cell becomes hypotonic. Very watery, very low in salt.
So low pulling power.
Exactly. Now, the salt concentration inside the cell is the stronger magnet.
Yeah.
So the water rushes from the hallway into the room.
The cell
It
floods,
swells up.
like a water balloon being overfilled.
Yes. And if that cell happens to be a neuron in your brain, well, you have a massive problem. Your brain is encased in a skull. It's a rigid bone box. There is absolutely no room for expansion.
Oh, wow.
If your brain cells swell, they have nowhere to go. They literally crush themselves and each other against the inside of the skull.
Which brings us directly to the most common disorder discussed in the text, hyponatremia, low sodium. Now, I want to pause here because this was a huge aha moment for me.
Okay.
When I see the words low sodium, my brain says, okay, I need to eat a bag of chips. I need more salt.
That is the most common misconception. And frankly, it's a dangerous one.
The source material says, and I actually underline this, hyponatremia is rarely a problem of too little salt. It is almost always a problem of too much water.
Correct. It is a dilution problem. Think of it this way. Imagine you have a perfect cup of coffee with 1 teaspoon of sugar. It tastes just right. Now pour a full gallon of water into that same cup.
It's going to taste like water. It's ruined.
Did you take the sugar out?
No, the sugar's still in there.
Exactly. You just diluted it. The concentration plummeted. That right there is hyponatremia. Your body usually has a normal amount of sodium, but you're holding on to so much excess free water that the concentration, the number on the lab report, looks low.
So if a doctor sees low sodium on a chart, their first job isn't to prescribe a salt lick. It's to figure out why there's so much water.
They have to play detective. And to do that, they classify the patient into one of 3 categories based on their fluid volume status. We call these the volemic statuses.
Okay.
It's basically, is the patient dry? Are they normal? Or are they wet and swollen?
Let's walk through these because the source makes it clear the treatments are completely different for each one. So, first up, hypovolemic, hyponatremia. Hypo means low. Volemic means volume, so low volume.
This is your classic dehydrated patient. Imagine a hiker who got lost in the heat, or someone who's had a terrible stomach flu vomiting for 3 days.
Okay.
Or, and this is very common, an elderly patient taking thiazide diuretics water pills that are just working a little too well.
What do they actually look like clinically? How can you tell they're dry?
They look dried out. We check their skin turgors. If you pinch the skin on their arm or back of their hand, it stays tented up because there's no fluid underneath it to make it snap back.
Right.
If their heart rate is fast, that's tachycardia because the heart is trying to pump what little blood volume is left around the body. Their mucous membranes, inside their mouth are dry and tacky.
So in this case, they're losing both salt and water, but they've lost a little bit more salt relative to the water.
Precisely.
Yeah.
So for this patient, the treatment is actually straightforward. You give them isotonic saline, normal saline. You just fill the tank back up.
That makes perfect sense. Okay, now the second category. This is the tricky one. Euvolemic hyponatremia. UVU means normal, right?
Yes, normal volume. And this is the patient that can fool you. Clinically, they look fine. They aren't dried out, but they aren't swollen either. Their blood pressure is normal. They look, well, normal. But their blood work comes back and their sodium is dangerously low, like 115.
So what on earth is happening here? If they have normal volume, why is their sodium so low?
This is usually the work of something called SIADH, the syndrome of inappropriate antidiuretic hormone.
That's a mouthful.
It is. Let's break it down. ADH antidiuretic hormone is your body's save water signal. It's a hormone released by your brain.
Okay.
Normally, you only release it when you're dehydrated or your blood pressure is low. It tells your kidneys, hey, hold on to every drop of water you can. Don't pee it out.
But in SIADH, the I is for inappropriate.
Exactly. The body is releasing this hormone for all the wrong reasons. Maybe the patient has pneumonia or a certain type of lung cancer or even just severe pain or nausea.
Yeah.
These things can trick the brain into releasing ADH.
So the brain is screaming, save water, even though the tank is already full.
Precisely. So the kidneys obey, they stop making urine, they hold on to all the free water you drink. This dilutes the blood. But, and here is the key to why they look euvolemic, the body senses that the blood volume is getting a little too high.
Yeah.
So it turns off the salt-saving systems. The kidneys actually start dumping sodium into the urine to try and balance out the pressure.
Oh, that's a disaster. So you're holding onto pure water A&D, you're actively peeing out your salt.
It's a recipe for rapidly dropping sodium levels. And the treatment is so tough because the patient is thirsty from the low sodium, but you have to restrict their fluids. You have to tell them, I know you're desperate for water, but you absolutely cannot have it.
That sounds awful. But the text mentions a breakthrough treatment for this, a newer class of drugs, the Vaptans.
Yes, drugs like kinevaptin or tolvaptan. These are fascinating. Think of the ADH hormone as a key. It fits into a specific lock, a receptor, in the kidney to close the floodgates and save water.
So these drugs, they're like putting gum in the keyhole.
That's a perfect analogy. They sit in the receptor and they block the hormone. They're AVP antagonists. So the kidney completely ignores the brain's save water signal and just flushes all that excess free water out into the urine. It fixes the dilution problem directly at the source.
That is incredible technology. Okay, let's hit the third category. Hypervolemic hyponatremia, high volume.
This is the patient who is visibly fluid overloaded. They are swollen. You can see the edema in their legs, their abdomen.
Who fixed this profile?
This is usually your patient with major organ failure. We're talking end-stage cirrhosis of the liver, severe congestive heart failure, or nephrotic syndrome where the kidneys are just leaking protein.
Now, wait a second. This seems like a paradox. If they are swollen with fluid, why is their sodium low? Shouldn't they be full of salt and water?
They are. That's the paradox. They have massive amounts of total body sodium, more sodium than a healthy person, but they have even more water. In these disease states, the body's fluid retention systems are in overdrive. They're holding on to salt and water like crazy. But the water retention outpaces the salt retention. So once again, it's a dilution issue. They're overloaded with salt, yet their blood test says low sodium.
So you definitely do not want to give these people salt.
No, never. If you give a saline IV to a heart failure patient with this condition, you will flood their lungs. You'll cause acute pulmonary edema. You could kill them.
Wow.
For them, you have to restrict both salt and fluid and use powerful diuretics to try and peel off all that extra water.
It just really highlights why a lab value of low sodium is not a simple diagnosis. It's a puzzle.
It's the ultimate clinical puzzle. You have to be a detective.
Now, before we move on, we have to talk about the danger of treatment. The text had a giant warning box about this, osmotic demyelination syndrome. It sounds terrifying.
It is. This is one of the things that keeps doctors up at night when treating these patients. It's a true iatrogenic, meaning doctor-caused disaster.
Why? What happens? What is it?
Okay, remember we said that in low sodium states, the brain cells swell up with water.
Right, the water rushes in.
Well, the brain is smart. If the sodium stays low for a few days, what we call chronic hyponatremia, the brain cells adapt. They actively kick out some of their own internal particles, their own solutes, to reduce their internal pulling power.
So they rebalance themselves with the watery blood.
Exactly. They reduce the swelling and find a new, lower osmolarity equilibrium. They make peace with the new normal.
Okay, that sounds like a good thing, a protective mechanism.
It is. Until an overzealous doctor tries to fix the number on the chart too quickly. If a doctor comes along and sees that low sodium and says, oh, let me fix that, and they pump in a bunch of hypertonic saline, the sodium level in the blood shoots up rapidly.
And suddenly the blood outside the brain cell is way saltier, way more hypertonic than the inside of the brain cell.
Exactly. And because the brain cells had already dumped their internal particles to adapt, they have no defense. The water gets sucked out of the brain cells violently. They shrivel up catastrophically.
And this causes physical damage.
It strips the myelin sheath, the fatty insulation, right off the nerve fibers, particularly in a part of the brainstem called the pons. It causes permanent, irreversible brain damage.
Myelin.
Yeah.
That's the coating that lets nerves conduct signals, right?
Yes. Without it, the nerves can't fire. The result is often a condition called locked-in syndrome. The patient is awake, they are aware, but they are completely paralyzed from the neck down. They can't speak, they can't move. They can often only move their eyes.
That is absolutely terrifying.
It is one of the worst outcomes in medicine. That's why the rule, the absolute mantra is, go slow. You never correct the sodium more than, say, 10 to 12 milliequivalents in a 24-hour period. Slow and steady saves the brain.
That's a lesson that you don't forget. Okay, let's flip the coin briefly and talk about the desert state. Hypernatremia, high sodium.
This is the opposite problem. This isn't too much water. This is a water deficit. You've lost water, or you can't get to water. So the salt you have becomes incredibly concentrated.
And the text points to a condition here called diabetes insipidus. I always associate diabetes with sugar, not salt.
It's a confusing name. The word diabetes actually just comes from the Greek for siphon or passing through. It means you're peeing a lot. In diabetes mellitus, the sugar diabetes, you pee a lot because the sugar in your blood spills into your urine and drags water with it. In diabetes insipidus, you pee a lot because that ADH water-saving system is broken.
So the save water signal is gone.
Either the brain isn't making ADH, that's central DI, or the kidneys are ignoring it, that's nephrogenic DI. Either way, the kidneys just dump gallons of pure dilute water constantly.
Got it.
Liters and liters a day. You can't stop peeing, and you have this raging, unquenchable thirst. And since you're losing pure water, your blood turns into a salty sludge.
And the brain, it shrinks, right? The opposite of hyponatremia.
Yes, the high sodium in the blood pulls water out of the brain cells. They shrink and can actually pull away from the inside of the skull. This can tear the delicate bridging veins that connect the brain to the skull, causing intracranial bleeding, a subdural hematoma.
Man, the brain is just so picky about its bathwater.
It demands stability above all else. It does not like rapid changes in tonicity.
So for treating this, I assume we have to give water. But again, is there a speed limit?
A very strict one. For the same reason as before, but in reverse. If you fix the high sodium too fast by just dumping in fresh water, the brain cells, which have adapted by hoarding their own internal salts, will suck that water in and swell up dangerously. You can cause cerebral edema.
So you can cause the very problem you were trying to avoid.
Exactly. So again, slow correction is key. We often use an IV fluid called D5W.
That's 5% dextrose in water. It's basically sugar water.
It is, but it's clever. It goes into the vein as an isotonic fluid so it doesn't shock the system. But your body cells immediately gobble up the dextrose for energy, leaving just the pure, free water behind to slowly and gently rehydrate the shrunken cells.
It's a stealth delivery system for water.
Exactly.
Before we leave this whole ocean of sodium, let's just touch on edema. When the system floods, but into the tissues, I've seen this, in older relatives with swollen ankles.
It's very common. It's simply an expansion of the interstitial fluid. That's the fluid in the hallways between the cells.
And there's a simple physical test mentioned in the text, the pitting test.
Yes. It's a classic bedside diagnosis. If you suspect edema, you press your thumb firmly into the patient's shin right over the bone, and you hold it there for a few seconds.
And then,
when you take your thumb away, you'll see a divot, a pit, like when you press into memory foam. And it just stays there. That tells you there's a significant amount of free fluid trapped in that tissue.
So to fix that, we need to get the kidneys to dump that fluid. We use diuretics. The text outlines a kind of hierarchy of potency.
That's right. They're not all created equal.
And the loop diuretics are the big guns.
Furosemide, brand name Lasix. They are the most potent diuretics we have. It acts on a part of the kidney called the loop of Henle. It is incredibly powerful. It blocks a huge amount of salt reabsorption, so the salt goes out in the urine, and water has no choice but to follow it.
And this is what you'd use in an emergency.
Absolutely. This is what we use for acute congestive heart failure when a patient's lungs are filling up with fluid. You give IV Lasix, and you can pull liters of fluid off in a matter of hours.
Okay, so that's sodium in water, the ocean. It's a massive topic. Now let's move to the structural components and the signals. Calcium and phosphorus.
The dynamic duo. These two are inseparable. They are the literal bricks and mortar of your skeleton. They form hydroxyapatite crystals, but they also act as these crucial second messengers and signals for your nerves and muscles.
Well, let's start with calcium. The text pointed out something that felt like a classic trap for young doctors, the relationship with albumin.
It is the classic medical school PIMP question. It trips people up all the time.
So what's the deal?
You see, calcium doesn't just float freely in your blood. About half of it, roughly 45 to 50%, is bound to a protein called albumin. Think of albumin as a taxi or a bus that's constantly circulating in your bloodstream.
Okay, so the calcium is a passenger on the bus.
Exactly. And while it's on that bus, it's inactive. It's just along for the ride. It's not doing anything. It's the free or ionized calcium. The passengers who have gotten off the bus and are walking around on the street that actually do all the important work of contracting muscles and firing nerves.
So what happens if you just don't have enough buses?
That's the trap. If a patient is malnourished or has severe liver disease, their liver can't make albumin, so the number of buses in their blood drops.
Okay.
So when the lab measures the total amount of calcium in the blood, the number will look low because there are no passengers on the non-existent buses.
But the number of passengers walking around on the street, the active ionized ones, that could be totally normal.
Exactly. The active calcium level is fine. The patient is fine. They have no symptoms. But the lab report flags it and says Hypocalcemia, danger. If you treat that number, you're treating a ghost. You can actually cause harm by giving them calcium they don't need.
So you have to do the math. You have to correct for the low albumin.
You have to correct the calcium level, Or better yet, just order an ionized calcium level directly.
That's a really crucial distinction. Okay, now let's talk about when the calcium is actually high. Hypercalcemia. The text points to two main culprits, cancer and hyperparathyroidism.
Those two account for more than 90% of cases. Hyperparathyroidism is usually a benign tumor on one of the little glands in your neck, and it goes rogue and just tells your bones to dissolve and release calcium 200 to 7.
But malignancy cancer is the really scary one.
It is. It's often a sign of advanced disease.
How does cancer raise calcium levels so much?
A couple of main ways. One is through bone metastasis. The cancer physically invades the bone and eats into it, releasing all the calcium that was stored there.
Right.
The other, more insidious way is that the tumor itself starts to secrete a protein that looks and acts almost exactly like parathyroid hormone. So it tricks the body into thinking it needs to dump calcium from the bones and absorb more from the gut.
And when it gets too high, we enter what the text calls a hypercalcemic crisis.
Right. When the levels get above, say, 14 or 15 milligrams per deciliter, this is a true medical emergency. The mnemonic we teach medical students is stones, bones, groans, and moans.
Okay, you have to break that down for us.
Stones refers to kidney stones. High calcium in the urine leads to stone formation. Bones is bone pain from the bones being broken down. Groans refers to abdominal pain, nausea, vomiting, constipation, because calcium slows down the gut. And moans refers to the psychiatric overtones, lethargy, confusion, depression, and eventually obtundation and coma.
And there's a danger to the heart as well, right?
A big one. High calcium shortens the QT interval on the EKG. It makes the heart's electrical reset happen too quickly, which makes the heart unstable and prone to dangerous arrhythmias.
So how do we get it out? What's the treatment protocol?
The very first step is hydration, hydration, hydration. You give lots of IV normal saline. This dilutes the calcium and also helps the kidneys flush it out.
Okay.
Then once you've rehydrated them, you can add a loop diuretic, like furosemide, to really push the calcium out into the urine. But for cancer patients, the real key is using special drugs called bisphosphonates.
And what do these do? Do they coat the bones or something?
In a way, they are directly toxic to the osteoclasts. Those are the cells that are responsible for eating bone. So they poison the bone-eating cells, and the bone breakdown just grinds to a halt.
Is it an immediate effect?
No, and that's the catch. They take about 2 to 3 days to really start working. So you need the saline and the diuretics to act as a bridge to keep the patient safe until the bisphosphonates kick in.
On the flip side, then, we have hypocalcemia too, little calcium. The source says this often happens after major neck surgery, like a thyroidectomy.
Yes, the parathyroid glands are these 4 tiny glands, each about the size of a grain of rice. They sit right behind the thyroid. A surgeon doing a thyroid operation will try their best to save them, but they can get bruised, their blood supply can be damaged, or they can even be removed by accident.
And if they're gone, your calcium regulation system is gone.
And it's gone. The calcium levels in the blood will just crash.
And the main symptom is tetany. This sounds like tetanus?
It's a similar concept. It's uncontrolled muscle contraction and nerve firing. It starts with a tingling sensation. We call that paresthesias, especially around the mouth and the fingertips.
Okay.
Then the muscles start to cramp up, especially in the hands. They can cramp into this claw-like shape. We call that Trousseau's sign. In severe cases, the muscles of the larynx, the voice box, can spasm. That's laryngospasm. And you can't breathe. It can be fatal.
Now, there is a magnesium connection here that the text calls out as absolutely vital.
This is the don't ignore the mechanic rule. It's another classic trap. You see, magnesium is absolutely required for the parathyroid glands to release their hormone and for that hormone to work on the bones and kidneys.
So if your magnesium is low,
your body cannot fix its own calcium problem. The parathyroid hormone system is paralyzed. You can pump IV calcium into that patient all day long.
and levels won't budge.
They won't budge. They'll just keep dropping. You have to check and fix the magnesium level first, always.
That's fascinating. Okay, let's briefly talk about phosphorus, calcium's energy partner.
The P in ATP, adenosine triphosphate. It is the literal fuel currency of every single cell in your body. No phosphorus, no energy.
The danger of high phosphorus hyperphosphatemia seems to be about this crystallization problem.
Yes. Calcium and phosphorus have a very strong chemical attraction. They want to bind to each other. If you have too much of both floating around in the blood, they will snap together and form solid crystals of calcium phosphate.
And where do these crystals go? They just float around.
No, they precipitate out of the blood and into the soft tissues, into your skin, your eyes, your blood vessels, your heart valves. There's a horrific condition called calciphylaxis that we sometimes see in patients on dialysis with uncontrolled phosphorus.
What happens in that?
The calcium phosphate crystals literally block the small blood vessels in the skin. The skin is starved of oxygen and it dies. It becomes necrotic. It creates these massive, excruciatingly painful, non-healing black ulcers. It's like your soft tissue is turning to stone.
That is a visceral image. And it's all driven by the product of calcium times phosphorus getting too high.
Yes. As a rule of thumb, if the calcium phosphorus product exceeds 55, you are in the danger zone for this kind of ectopic calcification. That's why in kidney failure patients, we are absolutely obsessed with lowering their phosphorus using binders pills they take with meals that sponge up the phosphorus in their gut so it never gets absorbed.
And conversely, what about low phosphorus hypophosphatemia? The text mentions a scary complication called rhabdomyolysis.
So if phosphorus is energy, ATP, then if you run out of it, your muscle cells literally don't have the fuel to maintain their own structure. Their cell walls break down, they fall apart, they dissolve. That's rhabdomyolysis.
And this includes the diaphragm, the main muscle for breathing.
It absolutely does. So severe, profound hypophosphatemia can cause acute respiratory failure. You simply stop breathing because your breathing muscles have run out of gas.
It's just amazing how these simple elements are the literal fuel for the entire engine. Speaking of engines, let's talk about the spark plug, potassium.
The electrical master.
This section of the source material felt the most intense. It really felt like every sentence was life or death in big, bold letters.
It is. Potassium is the primary determinant of the resting membrane potential of your cells. It decides the threshold for when your heart muscle beats and when it rests. A slight change can mean the difference between a normal rhythm and cardiac arrest.
Let's start with hypokalemia low potassium. Again, diuretics are a common cause here.
Yes, loop and thiazide diuretics are notorious for making you pee out potassium. It's the single most common cause of hypokalemia in clinical practice.
And the Hertz response is strange. The EQG shows these things called U waves.
Yeah, it's a specific finding. The electrical reset of the heart gets delayed and becomes unstable. You can see this new little wave pop up on the monitor after the T wave, which we call a U wave. It's a sign that the heart muscle is electrically irritable. It's twitchy. It wants to fire when it shouldn't.
The treatment rules were very, very strict here. The text says oral is safer than IV.
Much, much safer. Your gut acts as a natural regulator of absorption. But if we have to use an IV, there's a strict speed limit. Generally, no more than 10 milliequivalents per hour through a peripheral IV.
Why so slow?
Two big reasons. One, it burns like fire. Potassium is incredibly caustic to veins. It causes a condition called phlebitis. It feels like someone is injecting fire directly into your arm.
Ouch. Okay, and the second, more important reason.
If you push it too fast, you will stop the heart.
Just like that.
Just like that. You create a temporary local hyperkalemia right around the heart as the bolus passes through, and that's enough to cause a systole, which brings us to hyperkalemia high potassium, the immediate threat.
This is the condition that immediately reminded me of lethal injection protocols.
It should. A massive, rapid bolus of potassium chloride is the agent used to stop the heart in lethal injections. A massive dose causes instant fatal hyperkalemia.
So what happens to the heart muscle? The text describes the EKG changes as a very clear progression.
It's a countdown to disaster, and you can watch it happen on the monitor. First, the T waves, which represent the heart's reset phase. They get very tall and pointy. We call them peaked T waves. That's the first warning siren.
And
then the QRS complex, that's the big spike that represents the actual heartbeat. It starts to widen. It gets lazy and spread out.
And finally, the last stage.
The sine wave. The QRS widens and merges with the T wave until the whole thing just looks like a smooth rolling hill. Up and down, up and down. This means the heart has lost all electrical organization. It's just flailing. Cardiac arrest is seconds away at this point.
So when a doctor sees this, they have to act immediately. The text outlines a three-pronged attack. I love how tactical this sounds. 1, stabilize. 2, shift. 3, remove.
It is a bomb defusal protocol. You have to follow the steps in order, and you have to do them fast.
Okay, step 1, stabilize. The first drug you give is IV calcium. But I was confused here. Does calcium actually lower the potassium level?
No, not at all. And that is the most critical thing to understand. You can give the calcium, and the potassium level in the blood stays exactly the same. dangerously high.
So what is the calcium doing then?
It's hardening the target. It stabilizes the heart muscle membrane. It raises the threshold potential, making it harder for that high potassium to trigger a chaotic rhythm. It buys you time, maybe 30 to 60 minutes of protection. It's a shield.
Okay, so the shield is up. Now, step 2, shift. We need to hide the enemy.
Right. We can't get all that potassium out of the body in a few minutes, so the next best thing is to push it from the blood into the cells where it can't hurt the heart.
And the main tool for this is insulin.
Yes. Insulin's main job is to shuttle sugar into cells, but it has a side effect. It also turns on a pump that drags potassium along for the ride.
But if the patient isn't diabetic, won't giving them insulin cause their blood sugar to crash? Hypoglycemia.
It absolutely will. And that can be just as dangerous. That's why we always give it as a cocktail. Insulin plus dextrose, which is sugar. We give the sugar to counteract the insulin's effect on blood glucose, while the insulin does its job of hiding the potassium.
That is very clever. The text also mentions albuterol, the asthma inhaler.
Yes. A high dose of albuterol, the same stuff in an asthma rescue inhaler, stimulates beta-2 receptors throughout the body. That stimulation revs up the sodium-potassium pumps on the cell walls and makes them suck potassium in. So we might put a nebulizer mask on the patient while we're setting up the insulin IV.
So the shield is up. The enemy is hidden inside the cells. Now, step 3, remove. We have to actually take the trash out of the body.
This is the cleanup phase. This is the only part that actually lowers the total amount of potassium in the body. We can use heavy-duty loop diuretics to make the patient pee it out, or we can use a binding resin, something like sodium polystyrene sulfonate. You drink it, and it binds to potassium in your gut, and you excrete it.
And if none of that is working fast enough?
Then it's an emergency call to nephrology for emergent dialysis. We hook the patient up to a machine and filter the potassium directly out of their blood. It's the ultimate and fastest fix.
It's just incredible that a medical team has to run through that entire complex protocol in a matter of minutes to save a life.
It's high-stakes pattern recognition. You see peak T waves on a monitor, boom, the protocol starts. Calcium, insulin, albuterol, call for help, go.
Finally, let's wrap up with the forgotten key, as the text calls it, magnesium. It feels like magnesium is always the sidekick in these stories, never the main hero.
It's often the last electrolyte on the lab panel that gets checked, but it is frequently the first one to be causing all the trouble.
So hypomagnesemia, low magnesium. The source says this is very strongly linked to alcoholism.
Yes. Chronic alcohol use acts as a magnesium diuretic. It makes your kidneys wasted. And people with alcohol use disorder often have very poor nutrition. That's why in the emergency department, you'll often see those yellow IV bags called banana bags. They're yellow because they're full of B vitamins, but they also contain a healthy dose of magnesium because we assume most of these patients are deficient.
And there is a specific deadly heart rhythm associated with low magnesium, a very strange name, Torsades de Port.
It's French for twisting of the points. And that's exactly what it looks like on the heart monitor. It's a specific type of ventricular tachycardia where the QRS complexes looks like they're twisting around a central axis. It looks like a twisted ribbon. It is lethal if not treated immediately.
And the treatment is just magnesium.
IV magnesium sulfate. It's the antidote. It immediately stops the twisting.
On the high side, hypermagnesemia. How does one even get too much magnesium? Is it from taking too many supplements?
It's rare unless you have bad kidneys. The most common scenario is what I call mom's medicine cabinet.
What do you mean by that?
An elderly patient, often with chronic kidney disease, who is taking over-the-counter milk of magnesia for constipation, or a lot of magnesium-containing antacids for heartburn. Their kidneys are failing and simply can't clear the magnesium they're ingesting, so it builds up to toxic levels.
And the symptoms are described as a progressive shutdown.
That's a good way to put it. Magnesium is a natural sedative. It's a smooth, muscle relaxant. At moderately high levels, you lose your deep tendon reflexes. If I tap your knee with a reflex hammer, nothing happens. Hyperreflexia.
And if it keeps rising?
It sedates your diaphragm. You get respiratory depression. Then it sedates your heart, causing heart block and eventually a systole. It just slowly turns off the body's power switch.
And is there an antidote for this?
Our old friend IV calcium.
Calcium again, it pops up everywhere.
Calcium is the direct physiological antagonist to magnesium. It immediately reverses the neuromuscular paralysis and the cardiac effects caused by the high magnesium. It wakes the system up just enough to get the patient safely to dialysis to remove the excess.
It really does seem like calcium is the universal stabilizer in this entire electrical grid.
It really is. It provides the structural integrity for the whole electrical system.
So we've toured the grid. Sodium and water, calcium and phosphorus, potassium, magnesium. We've seen how they work and, more importantly, how they can fail in spectacular ways.
It is an incredibly complex, interconnected web.
If there's one big takeaway from all of this for the listener, something for them to really mull over, what would you say it is?
For me, it has to be that concept of interconnectedness. You absolutely cannot treat these numbers on a lab report in a vacuum. A low calcium might actually be a low magnesium problem. A low sodium might actually be a high water problem. A high potassium might be caused by the very insulin you gave to treat high blood sugar. The body doesn't have silos.
Everything talks to everything else.
Constantly. Homeostasis isn't a static state. It's a dynamic, ongoing negotiation between all of these different elements all the time.
And it makes me think about just how incredibly resilient we are most of the time. We eat a salty pizza, we run a marathon and get dehydrated, we drink alcohol, we take medications that challenge the system, we throw chaos at this grid every single day.
And the kidneys, the brain, the hormones, they just silently adjust. They balance the books without us even knowing, until one day, they can't.
And maybe that's the final provocative thought. Modern medicine is amazing. We have Vaptins and bisphosphonates and dialysis and insulin cocktails. But every single time we intervene, every time we push one of these levers, we are challenging those ancient evolutionary balances. We fix one problem and we force the rest of the grid to try and compensate.
It is the great paradox of medicine.
Yeah.
We're mechanics trying to fix an engine while it's running at 100 miles an hour.
Well, they'll certainly never look at a bottle of water or a bag of chips the same way again. I think I'm going to appreciate my sodium-potassium pumps a little bit more today.
Stay balanced.
Exactly. Stay isotonic, everyone. Thanks for listening to The Deep Dive. We'll catch you on the next one.